So I'm Professor Dr. Vivek Gupta, cardiologist in Delhi Apollo Hospital. Today I'm in London during the London Valve meeting, and today is 26th of November 2024. So I have the privilege of having our dear friend and my mentor. She worked with Professor Helene Cribier, who was the father of TAVI, and I used to work with both of them, Dr. Cribier and Dr. Helene Eltchaninoff. She's Russian origin, that's why her name is Helene Eltchaninoff. It's a very difficult spelling, but I know by heart. So she's a very eminent cardiologist from France, and so I know her almost for last 25 years, ever since I worked in 1996. She is now the chief of cardiology in the hospital Charles de Gaulle, where I worked in 96, 97, 98 when Alain Cribier was a chief. She's doing a lot of eminent research and also doing some related to activities. So we always say that father of TAVI is Alain Cribier, but she was equally involved. I can now say that father of TAVI is also Dr. Helene Eltchaninoff. Her spelling is Helene, and she's a fantastic person personally, and she has taught me and taught a lot of people, and she's a very good teacher. And she is a fantastic operator also, because I've seen her working in coronaries. And now recently we saw that she finished a TAVI case, transcatheter aortic valve implantation, in around less than 40 minutes. And I vividly remember the first case from India was done in November 2011, when the TAVI was not available in India, and we flew one patient. And I saw Dr. Cribier and Dr. Helene Eltchaninoff. I was the third operator. I was just a scrub, but they did the case in conscious sedation in 30 minutes, starting from device of closure per close till the point. So I would like to hear from her, from I would say the horse's mouth, regarding the development of TAVI, and because 96, 97, 98, you had not started the animal experimentation. It was after that you started this. At that time I already come to India. So I wanted to know what actually you faced the problems along with Alain Cribier regarding the development of the valve technology, and how actually it came up, because now you know better than anybody else in the whole world, I would say. So can you just introduce a little more and then talk about the procedure?
So yes, I had the chance and the pleasure of working with Alain Cribier, and in fact I decided to go to Rouen because I was told that there was a crazy doctor doing a balloon valvuloplasty in Rouen, and I thought it was a good idea to go there. And immediately I was fascinated by what Alain Cribier was doing, saving the life of these patients with aortic stenosis. We had many physicians coming from abroad, patients coming from abroad. We had Alain Cribier traveling all over the world. So I immediately decided to do interventional cardiology, to do the same, in fact.
You were trained in Paris and then moved to Rouen?
Yes.
Just because of Alain Cribier?
Yes. And I didn't know him before. And he was both an innovator and a very nice man, because he, Vivek, you knew him very well. He's very kind, very simple, a lot of humor, a lot of he liked to have fun, a very human person, playing piano, etc. So very curious of everything. So we had a good time, and the professional life and everything around was always fun. And so the difficult part was, in fact, first to make people accept his idea, in fact, because he has this crazy idea at the end of the 80s to put a valve through the femoral artery. And I was a resident, I couldn't even understand how it could work, because the valve is quite big, and how could we imagine to have it inserted via the femoral artery. So for him the most difficult part was to try to convince and to make the concept acceptable by everyone. We were the only one in the team in Rouen to believe in his idea, because we knew him. So it took for him at least almost 10 years to have a prototype. This was the first initial very big problem, because from the concept you need a prototype to go further, to do animals and to do human. So he did the one step which was very important. It was before animals, before ships, we did cadavers, and it was very important because at that time many patients were dying from aortic stenosis in the department. So it was quite common to do an autopsy to understand. And so we went to the anatomopathology lab, and we implanted a stent in the aortic valve. And this study on cadavers demonstrated that it was possible to enlarge the native aortic valve, open it by placing a metallic stent, and that you could have a very circular opening of the stent, and you could respect the surrounding structure, coronary arteries above, mitral valve and septum below. So it was a really very important proof of concept of what we did on cadavers. And then
that was in Rouen only?
It was in Rouen. It was in Rouen only. Yes, it was in Rouen only. And then the startup was created. You know, they created a startup with Martin Leon and 2 engineers, and it allowed to work with a company in Israel to make a prototype, because there was an engineer who believed in the concept and who made a prototype which looked like the Sapien valve we are using today. And once the prototype was made, we could do experiment in the ship. And we went with Alain almost more than 1 year, once a week, to a lab in Paris, and we implanted the valve in 100 sheep. So it's a lot of sheep. Sheep, but because sheep, the anatomy of the sheep is close to the one of human for the annular size. And we had only a 23 mm valve, and we are used to go through the carotid. The only problem is that the sheep has no aortic stenosis, and there is no animal with aortic stenosis. So it was very difficult, because we had embolization of the valve. It won't stay because there was no calcium. But the first one worked. So the first one worked, and it allowed to get money from investors and to improve the device, etc. And finally, after 100 sheep, we had many cases with success. 100 sheep, yes. And we did a long-term analysis to prove that the durability was good enough to move to human. So we did.
That means you used to put a valve. Sorry for disturbing.
Yes.
You used to put the valve in the living sheep.
Yes.
And then used to leave the valve.
Yes, we used to leave the valve.
They lived.
Yes.
Or they used to continue to living.
Yes.
There was no post-mortem, something like that.
We did also post-mortem. We did both. And the one who lived, it's a little complicated, but since the valve could not stay in place in the native aortic valve, we did experiment in placing the prototype in the pulmonary valve or in the. And finally, after this successful sheep, we were facing a patient who came from the north of France for balloon valvuloplasty, in fact, but he was not improved, and Alain Cribier decided with the startup team that the patient could be the first in man. So it was very impressive, because they had a lot of discussion between Martin Leon, Alain, etc., because the patient was very, very fragile. He was only 57, he had a bicuspid valve, he had no arterial access, so we are obliged to do transeptal implantation.
But if he had the arterial access, would you have done
arterial
at that time?
No, because the goal was to do arterial implantation.
Or from the beginning?
Yes, from the beginning. Okay. The idea
this
of
I did not know.
Yes, it's very important, because when you hear different people, they think the idea was to do transeptal, but not at all. I mean, the idea was to place it like a stent. Arterial retrograde approach, like from femoral, it was obvious, like a simple catheterization technique.
A lot of people think that the retrograde has been devised by somebody else.
No. It's totally wrong. It's the initial idea is to do it as a stent, coronary stent, from femoral artery using retrograde approach, and we were obliged by the first patient who didn't have arterial access to use alternative approach, which was transeptal. It's just because the first case was like this. And then the French regulation obliged us to do the next 40 cases with transeptal. But it's important to have this discussion, because still we did the first in-world implantation using arterial retrograde approach in the one of the first cases, because the patient had mitral stenosis, and we were allowed to use the arterial approach. But again, the goal was, of course, to do it as a stent procedure.
Because many people still think that it was not John Webb, or who was.
No, it's not. It's no. They think, but they don't know the true story.
Yes.
I mean, John Webb, it's different. He came later.
Much
later, when the startup was acquired by Edwards.
Okay, he came after Edwards.
Yes, he came
okay.
after Edwards, and he came because the Edwards improved the device, and he improved the device, and the device was the French regulation did not accept to use this new device in France. And so the new device was first used in Canada by John Webb. This is the only...
Oh, because of the French regulation
yes.
was not allowed.
So that's the only thing, and we were very disappointed because the innovations come from us.
Sometimes the credit goes to something.
Yes.
Because even I did not know that it was retrograde you planned earlier, because you were doing from carotids already. Already sheep you were doing
yes,
carotids.
Yes, because the femoral artery of the sheep was not big enough.
No,
the carotid is better. So it's good to know first the true story, and it's good to veiculate it. So we did it. It was very successful, as you know, and the first case already demonstrated that it was feasible, that there was no embolization, there was no coronary occlusion, there was no conductive disorders, there was no mitral regurgitation. So we demonstrated, in fact, almost everything, and from the first case we understood that it will work. So it was a major step.
And
then
you know the story.
Because of Dr.
Cribier, because he knows transseptal so well.
Yes.
If it was somebody else, it would not have been possible to do that.
Yes.
Because he was a master of transseptal also.
Yes, because we did a lot of mitral balloon in way. He invented also the mitral commissuratome. As you know, we went to India. He went to.
He was master of all.
Yes, he was master of everything. Anyway, he was very good in CTO, what we call now. He was a very good interventional cardiologist. And then the story, the trials, everything. But really, what we can remember from Alain is that he had really crazy idea. He was a genius, because this idea, I mean, you could not imagine that it could be feasible to implant a valve without opening the chest. And now for young people, for anyone, here we are the PCR London valve, it's something which is obvious. People can even not understand that at that time, the concept was not, it was impossible to imagine it would be feasible. So it's very interesting.
A lot of people, this London valve meeting which is happening is, I think, full credit goes to Alain Cribier, because he devised this valve. Now this is a huge meeting now.
Yes,
a lot of people, they don't know. So,
I think people know, but
the young people.
He opened the field to structural valve disease, to mitral tricuspid, to this meeting, to imaging. CT scan was not used. We have a big program on aortic stenosis research, basic research on the disease itself, on the progression of the disease, on awareness, on diagnosis, on a new innovation. We're working with a startup named CardiaWave, which uses a therapeutic ultrasound to soften the aortic stenosis. So it's our partner in our research program, and still there is a lot of things to do. So all the credit goes to his incredible idea.
Not only idea, but he did it.
He did it.
That's
You're
most
right.
important.
Yes, he did it.
Despite the Medtronic and Edwards refusing to completely sponsor
all
it.
the companies refused initially to develop a prototype. He was very, we have to give credit to his character, because he could have abandoned 100 times. And he never abandoned, because he knew that there was clinical need for patients, and he knew it will work. He was absolutely sure that his idea was right. And it's very funny, because I remember when he was telling that at the end of the 80s, when patients had restenosis after balloon valvuloplasty, he was saying, let's put a valve, and it took 10 years to
develop,
it's okay,
make it. It's working. Okay. So I remember vividly when I joined him in '96, he was in the car, and he said, Vivek, I have two projects. One project was this, and another project, he said, percutaneous bypass.
Yes.
He wanted to develop that also.
Yes, he wanted to develop percutaneous bypass. He said, I remember, but he told me, probably I am now too old to develop another project, but he said it should come because you go in the pericardium and you do a bypass between the two pericardial how do you say, membranes, and you enter the pericardium.
Can you do his mission?
But you know, for electrophysiology, they go in the pericardium to do ablation. So in fact, it's probably possible to do that. You enter the pericardium and you re-enter after the stenosis, and you put a long covered stent, and it's a bypass. But don't give the idea.
Okay. So I'm thankful to Dr. Helene. That we are here in London Valves, and was memorizing Dr. Cribier also. And one more thing which I wanted to tell the audience regarding my presence. At that time, I was very, very younger, and he was too much involved in so much of research. Helene, I want to tell you that once he was not happy and he was not smiling. So if he was not smiling on me, I used to feel stressed out. Suppose in the morning, so once I told him, "How are you? You're not happy with me?" What he said, "Vivek, you're not even 1% of the problems." Okay. So thank you very much, Dr. Helene, and I'm very happy to be here in London Valves and learn a little more about Dr. Cribier did. And today is 26th of November. Now we'll have. She is one of the best interventional cardiologists I can say of the world, and she do a lot of work, and all the other projects she will take up. We'll talk to her later. Thank you very much.